morning, ladies and gentlemen. Thank you for attending the event. I'm Lily Xiao, Professor of Nursing at Flinders University, Australia. Can you please use the chat box to introduce your name and the organization you are associated? This event is part of the knowledge exchange activities in a project entitled Strengthening Professional Collaboration in Dementia Caregiver Education and Research, while the prevention and the evaluation of the eye support program in Australia and Greater China. This project is funded by the National Foundation for Australia-China Relations, Australia government. Flinders University is the leading organization of the project. Our partners in Australia are University of New South Wales, National Aging Research Institute, University of Wollongong. Our partners in Greater China are Peking University, Xi'an Jiaotong University, Taipei Medical University, the Chinese University of Hong Kong, and the Wukai Nursing College of Macau. I'm very delighted to introduce today's presenter, Scientia Professor Henry Brodney. Professor Brodney is the co-director of the Centre for Health and Brain Aging. He's also a senior psychogeriatrician at the Prince of Wales Hospital, Sydney. He was the previous president of International Psychogeriatric Association, chairman of the Alzheimer's Disease International. In 2016, he received the Ryman Prize for his achievement that enhances quality of life for older people. Please join me to warmly welcome Professor Henry Brodney. Over to you, Henry.
Thank you very much, Lee. It's a pleasure to be here with you this morning, and I'm going to be talking to you about dementia care policies and practices in Australia. I work at the Centre for Healthy Brain Aging and the Dementia Centre for Research Collaboration, both at the University of New South Wales in Sydney. So just some background. Australia is a country of 6 states and 2 territories. The combined population is small by Chinese standards. It's just under 26 million people. About 16% of the population are aged over 65. More than a quarter are born overseas, and 43% have at least one parent born overseas. So we are quite a diverse community. And if you look at languages spoken at home in Australia, 3/4 speak English only, but the other quarter speak a variety of different languages, the most common of which is Mandarin, closely followed by Cantonese. So you see, the Chinese presence in Australia is strong. The proportion of older people in Australia, as in most countries in the world, has been steadily rising. A century ago, in 1927, we had under 5% of the population aged over 65. So now we have 16%. Lifespan has increased by 3 months every year for a century. So this means there are about 4 million people aged 65 or more, and almost 500,000 people aged 85 or more, or 2% of the population. As expected, there are more women than men, and that disproportion increases in very late life. This is a population pyramid, and you see males on your left and females on your right, the lighter colors being the year 2000 and the darker colors being the year 2020. Now in Australia, there are over 600,000 people, or 3.3%, who are Aboriginal or Torres Strait Islanders, Indigenous people of Australia. They have suffered multiple hardships over the 200 years that Australia has been colonised by Europeans. They have a shorter lifespan. They access aged care services at a younger age. So 65 is the cut point for most Australians, but for Aboriginal people, it's 55. The proportion of Aboriginal people who are older is much lower than the general population because of their reduced lifespan. And they mainly live in rural or remote areas. So less than a third live in the major cities, whereas for non-Indigenous people, most Australians live in the big cities. So what's our system of healthcare? First of all, when people turn 65, they are eligible for an age pension, or if they've been military, a veteran's pension. And 3/4 of all Australians receive a pension in old age. Many of them are on part pensions because they have their own private means. In 1992, it was introduced in Australia that we had to have compulsory superannuation. So for example, I give 9% of my salary into my superannuation. It's a compulsory form of saving. So this means it will provide for my old age and will have less for the government to provide because I'll have some of my own means. Dementia in Australia. We have almost 500,000 people with dementia in Australia, and that's projected to double by 2056. The cost, and it varies by different estimates, is over $17 billion, or 1% of our gross domestic product. I spent quite a bit of time talking about Aboriginal people because they have a higher rate of dementia, almost 3 times the rest of the population, or more than 3 times. Many people with dementia live alone, and maybe almost 30,000 people are aged under 65 when they have their first symptoms or first diagnosis. Healthcare in Australia accounts for almost 10% of our gross domestic product. And the cost is rising more than inflation because demand is increasing, because the investigations and the medicines and procedures are becoming more expensive. And of the 10%, 1/10 is accounted for by dementia alone. One Australian dollar, actually this morning I heard it was 73 US dollars. Care is funded through a combination of public funding and private health insurance. There are incentives to insure privately. In fact, if I earn more than a certain amount, I'm well paid, I have to take private insurance or I have a penalty in my tax. Most people, when they go and see their doctor, their general practitioner, they are bulk billed. In other words, the doctor charges the government 85% of the fee, and the patient does not have to pay out of pocket. For the doctor, it makes it simple, and they get 85% of the fee without any bad debts. Many specialists charge much more than the scheduled amount, and people then have to pay an extra amount, the gap. Medications are subsidized. About 1 in 3 of all medications are on our benefit scheme, which means it's very cheap for pensioners, only $6 for a script. We have 180,000 people in nursing homes or residential aged care facilities. Most of them are in permanent beds, some in respite beds. There's a lot of controversy in Australia right now about maintaining the safety and quality of care. So there's an agency set up that organizes inspections of all these facilities. And there are criteria, there are standards which must be adhered to. And if a nursing home does not meet these standards, they get a warning, and they may even be closed down. About 3 or 4 years ago, we had a major television expose, a 2-part series about the abuse of people in nursing homes. People were being neglected, physically abused, and the videos were terrible. Families had put secret cameras in their loved ones' rooms in the nursing home and provided them to the television station, which showed these, and they were shocking. It galvanized the government into action. And it set up a royal commission, which is a big deal in Australia. It's a very important inquiry, a governmental inquiry with a big budget. And they met for over 2 years, and they gave their report with many recommendations in March this year. Now, to go into nursing home, if you have no money, if you're on a pension, then you don't have to pay extra. The nursing home will take 85% of your pension and will be able to look after you. So no one is left out. But if you want a better nursing home, a single room, if you have money and you're not on a pension, then you have to pay more. And so there is a bond to go into the nursing home, which can be very expensive. In a very luxurious nursing home with a view of Sydney Harbour, the bond can be up to $2 million. The bond is a bond, so it's not kept by the nursing home. When you die or leave the nursing home, the bond goes back to your estate or to your family, minus a small amount. There is also a daily fee, and this typically is $200 a day. So I'm giving all these figures in Australian dollars. So how is all this paid for? Well, we pay tax. I'm on the top rate. I pay 45% of my income to the government, plus I pay an extra 1.5%. This is called the Medicare levy. For all people, public hospital care is free. Older people are 3 times as likely to be in hospital than younger people. I'll skip the rest of this. So let's imagine you have a person, or you are a person with dementia. How will you get a diagnosis? How will you get these services? I'll come to diagnosis in a minute. So let's imagine you have got a diagnosis and you need some help at home. You can't dress yourself, you can't wash yourself, your family is unable to help in everything. You can get some services from the government. But to do this, you need to have an assessment to see that you are eligible. And these are done by aged care assessment teams, which are distributed throughout the country. The aged care assessment is used to determine eligibility for subsidised care, which might be physical care, psychological, medical, cultural, or social needs. These aged care assessment teams are the gatekeepers for all services. If a person wants to go into a nursing home, they have to have that assessment first to see they're eligible. So let's go back to you as the patient. So you're worried about your memory, you want to get an assessment. Your first call is through your general practitioner, your GP. GP assesses, and usually they refer to a specialist for confirmation. You cannot see a specialist directly without going through your GP. or if you do, you won't get any government subsidy on the cost of the consultation. The specialists are mainly neurologists, geriatricians, and psychogeriatricians like me. Neurologists generally do not become involved in continuing care. Geriatricians and psychogeriatricians do. And as psychiatrists, we're also involved in the behavioral and psychological symptoms of dementia. One of the challenges in Australian healthcare is there's a split between the federal or Commonwealth system and the state system. The Commonwealth is responsible for the nursing homes, for aging, for community care, for seeing a doctor in their office, for subsidising medication, and for nursing homes. The states are responsible for mainly for the hospitals and mental health care. A few years ago, Australia introduced a national disability insurance scheme for all people under 65 with a disability. And that includes dementia, if they got the dementia before the age of 65. People can navigate a website called My Aged Care to access these services. People complained it's very difficult to navigate and takes quite a bit of time, but it works. So let's say I have been diagnosed. I went to my specialist to confirm the diagnosis. I may have been put on a drug for the treatment of Alzheimer's disease, if that's the type of dementia I have. And that's had modest effects. I'm now declining. I need some help. I have my aged care assessment done, and I'm deemed to be eligible. And depending how dependent I am, how much care I need, I can get a package of care which ranges from basic care, level 1, to level 4, 3 hours a day equivalent. So the cost of these subsidised is $9,000 for basic care, up to $52,000 per year. These are partially subsidised. So the consumer contributes depending on how much money they have. And we now have this system of consumer-directed care, where the consumer must say, look, I need help with housework and with changing the light globes. I cannot stand on a chair to change the light globes. Plus I need some help with showering and dressing. And so a package is provided, which meets the needs of that consumer. There are many types of community services, and these are shown here. Home help, home nursing, community transport, attendance at a day centre, respite care. And respite care can be in a day centre or can even be into a nursing home. And people can be eligible for up to 9 weeks a year, 63 days. It's heavily subsidised, but the people still have to pay a certain amount. And this gives the family or the carer a break, respite. There are some other initiatives that the government set up some years ago. One is called Dementia Training Australia. And the aim here is to provide health professionals with skills and information about looking after dementia. So it could be people with no professional background, aged care workers or assistants, right through to registered nurses. Another initiative was Dementia Support Australia. And the aim of this is to help in the management of behavioural problems which are associated with dementia. We know that 90% of people with dementia will have some behaviours of concern during the course of their dementia. Some of them, many of them, can be managed by giving good advice to the families or to the care workers, how to look after the person, understand the communication they are trying to give with their behaviour. But sometimes these don't work and you need specialists. So that anyone, the family, the GP, the nursing home or the hospital can ring up and ask for a dementia behaviour management advisory service to give advice or come and see the patient. If the behaviour becomes intractable, very severe, and is unable to be managed, there is a next level called the Severe Behaviour Response Team. The numbers here are much smaller, obvious reasons, because the Severe Behaviour Response Team will actually go into the home, the patient's home or the nursing home, and spend a day or 2 days, even 3 days, trying to work out how to manage this behaviour. In the last year, Australia has in the process of setting up special dementia care units for people with extreme behaviours unable to be managed elsewhere. These are small units, 8 or 9 beds, distributed through the country. And Dementia Australia is another important element in our package. This is a community group, volunteers, funded by the government, funded by contributions, donations, and membership fees. And it provides advocacy to government. It provides direct services for people with dementia. It provides a counselling 1-800 number people can call. It provides a number of different services and actually funds research as well, like the Alzheimer's Association in the US or the Alzheimer's Society in the UK. So you see the headings here: information, support, fundraising, research. There's a lot of different information on this website. And in 2006, another initiative was formed, which was the Dementia Collaborative Research Centre, which I lead one hub of. And this was trying to bring together researchers, clinicians, people with dementia, family carers and policymakers to try and embed research into everyday practice. So it all sounds rosy, it all sounds wonderful, but with all of this that we have, and we're a rich country, Australia, we still have challenges. We have stigma. People don't want to hear about dementia. People don't want to admit they have dementia. I'll come back to this. We know a lot more about prevention. We know that 40% of the risk of dementia is attributed to environmental factors that we can do something about. But how do we get people to do this? How do we embed prevention at a population level? There are delays in diagnosis. People wait 2 to 3 years from symptoms to diagnosis. It's not good enough. There's problems with post-diagnostic care. After the diagnosis, what next? I'll come back to that. There's a lack of referral services. People are not being referred to Dementia Australia. They're not being referred for occupational therapy or speech therapy. Behaviours are not well managed. There's high use of antipsychotic and other psychotropic medications. And we all know the side effects of these can be serious. I talked about the aged care packages. Well, they're good, but there aren't enough of them. People can wait a year or longer for a level 4 package. In fact, many people have already gone into nursing homes or died before they got their package. This is one of the big recommendations from the Royal Commission. And the government stepped up in May to provide an extra $100 million for more community packages. We face workforce shortages. Most of the workforce in aged care are overseas people, migrants in Australia, who provide tremendous support. But of course, with COVID, they're not coming. And also our workforce is aging and young people are not coming into it. And being a researcher, another challenge is we don't get enough funding for research. If we compare ourselves to diabetes, heart disease, or cancer, even though the disease burden of dementia is equal to all of them, we get much less funding. So you'll recognize these famous people with dementia at the top: Reagan, Churchill, Thatcher, Rita Hayworth, Charlton Heston. You probably don't recognize the people below them because they're Australian icons: Hazel Hawke, Jeannie Little, and Don Lane. But the point of giving you this slide is to say, by having more exposure to dementia, by public figures coming out and talking about the dementia, stigma can be reduced. We had this wonderful series on television here called Old People's Home for 4-year-olds. And what they did was they took a class of 4-year-olds into a nursing home, and then the second series into a daycare center. And the 4-year-olds brought the old people to life. It was just a beautiful thing to watch. Lovely series. And this is the sort of thing we can do to reduce stigma and bring older people back into the community. So what I'm going to talk about now is some problems and solutions. The problems are in red, and the solutions, I hope, are in green. They don't look so green to me at the moment. So I mentioned that 40% of dementia risk is attributable to potentially preventable causes. The problem is we lack programs to promote these. So what can we do? We need to educate the public. The public have become pretty good about recognizing risk factors for heart disease, getting their blood pressure checked, getting their cholesterol checked. The public is becoming much better at recognizing the first symptoms of stroke. Face drooping, loss of speech, loss of feeling in a hand, and getting treatment early. So we need to educate them and to GPs about having the same attitude for dementia prevention. And we know it's never too early and never too late to start. We are researching, we've done a randomized controlled trial of an online program to try and help people improve their diet, their physical exercise, their brain exercises, brain training on computers, and treatment of depression or anxiety. We don't have the results yet. Maintain Your Brain. If you look up Maintain Your Brain, you can see that trial. Next problem. I mentioned the delay of up to 3 years from symptoms to diagnosis. About half of people with dementia are not diagnosed by their GP. How can we fix this? In all countries, this is a big issue. GP training programs is important. We've been doing this. We've managed to reach 5,000, which is about 1/6 of all GPs in Australia. Our budget in May this year allocated money to train 1,000 GPs each year. And in many countries, it's not GPs, it's primary healthcare workers with a lower level of training. India have done that very successfully. The next problem is after the diagnosis, there's a void. People don't know where to go next. They feel like they're just walking into a black space and feel lost. And so Dementia Australia has now a post-diagnostic care package. We have developed, and we're going to launch on World Alzheimer's Day, the 21st of September, a web link called Forward with Dementia. Our internal name is Cognizance, but if you just Google Forward with Dementia, but wait till after 21st of September, you'll see our website. Now, this will only be, at the beginning, in English, Dutch, Polish, and French. But we are partnering with World Health Organization, Alzheimer's Disease International. And once the package is fully developed, We hope it'll be translated by countries into their own languages. Another initiative in Australia has been the establishment of the Australian Dementia Network. And we're following Sweden here. They have a registry. Everyone who's diagnosed with dementia is offered the opportunity to be on that registry. And over 75% of all patients diagnosed in Sweden are on that registry. It means you can have good statistics, good data to work out what the problems are and look at how people are progressing and how well people are being treated or being investigated. Are they meeting the criteria? We also have a memory clinic registry, which is just being set up, which will try and standardize guidelines for memory clinics around Australia. Next problem. I mentioned that 90% of people living with dementia in residential care experience change behaviors, or BPSD. We know that over 20% of residents in care are on antipsychotic medication, which have a higher rate of stroke, of death, falls, pyramidal side effects, and many others. So how can we reduce this? And we are, but still a long way to go. So by bringing in the Dementia Behaviour Management Advisory Services, part of Dementia Support Australia, they can provide alternatives to medication, behavioural management, environmental changes, working with families, educating staff. The government has also introduced restrictions, particularly on antipsychotics. They can only be prescribed with subsidised medication for 12 weeks. And there are now rules about how permission has to be provided. There are new regulations which came into effect last week, or 2 weeks ago, sorry, on restrictive practices, keeping people imprisoned, as it were, in their rooms or in nursing homes, or not being given the freedom that they're entitled to. I mentioned the special care dementia units, which are opening around Australia. And in our state of New South Wales, we are just developing a program for people with really extreme behaviours, usually severe aggression. Next issue, carers. This is what we're on about. This is what Lily Zhao is leading. How can we decrease the levels of stress and depression for carers? We know that carers have high levels of depression. They're socially isolated, their physical health suffers. And even though the person with dementia suffers, often the family suffers differently and sometimes more than the patient. We know in Australia that non-English speaking carers do not access services to the same level as English speaking carers do. So we need programs to reach those other languages, the 25% of Australians who don't speak English at home. And so the solutions, Dementia Australia is working on this. There are training programs for carers. There are community supports, day centres, and residential respite care, all aiming to reduce the level of stress. Many of the programs are now in different languages, tailored for different community groups. We have a huge Arabic population in Australia. There are also financial support for carers, called the carer's pension or the carer's allowance, which enables them to not have to work and look after their loved one. What about community supports? Well, here are the problems. Access is cumbersome. It's tricky, it's difficult. The aged care website really takes quite a bit of patience to navigate. And filling out the forms, particularly for old people who are not computer literate, is quite difficult. There's often a 2 or 3 month wait for the aged care assessment team. And there can be, as I mentioned, a 1 year wait or more for an aged care package, particularly a high level aged care package. Some countries have a system of having a dementia navigator or key worker, someone who the family and the patient can contact and provide continuing support over the journey of dementia. So the solutions, well, I think they're difficult. You know, the website's getting perhaps a bit better. There are certainly more aged care packages available. And I think we need to have evidence. We need to show that if we have good community care, it reduces the cost of nursing home care, because governments will listen to economic arguments. This is a clip. This is the clip from that program on television about cases of abuse and premature deaths in nursing home. You see this lady lying here with a teddy bear nestled to her bosom, and she has cuts or bruises on her forehead. And it really is quite distressing. And so that's another problem. We have to improve the level of training. I mean, many nursing homes are fantastic. They provide fantastic care. They're caring, they're very engaged with the patient and the family, and they provide a good quality of life. But some others don't. I mentioned the aged care workforce. We have problems with recruitment. The wages are poor. The workforce themselves are getting older. And many of them lack skills or training, which is why Dementia Training Australia was set up. We've relied on overseas nurses or aged care workers to fill the gaps, but this has become a real problem just in the last year or so. Other problems are our organisation. We have this divide between federal and state. We do not have a national dementia policy. That's in progress, but it's over 2 years since it's about 2 years since we had the last one, but I think it's close. There have been the scandals regarding abuses in residential aged care and the other things I have mentioned. The solutions, I mentioned the plans under development. The Royal Commission, which I mentioned, provided 148 recommendations. The government's responding. They provided $229 billion over a few years, I think it's 4 years, to improve things. There's stronger regulations and monitoring, and subsidies are subject to means tests because the cost is so high. Research, as I mentioned, is less relative to other conditions. We have had some injections of funding, but it still falls short of what we need. One of the big issues in Australia is a lack of good data. That's in many countries. Scandinavian countries do this brilliantly. And we're trying to rectify this now. And as far as funding research, if you can get money to find a new drug, that's good. But it's much harder to get funding to look at better services. So let me finish up here. We have a very good system compared to many countries. And the challenges continue. And that's why our team, led by Lily Shao, is working on this and many others in many different ways. The solutions are never going to be just one thing. It's many things. And we all need to work together to advocate, to work with government and with policymakers to demonstrate that investment actually pays dividends, and to educate the public that they should be asking for these things. So these are a couple of these are two of our two websites, the Centre for Healthy Brain Aging, or CHEBA, and dementiaresearch.org.au, and that's my email address. So thank you very much, Lily. I'm happy to take questions.
Thank you, Henry, for your great presentation. This is a most comprehensive presentation I have heard. Thank you very much. And thank you for our audience for participating in the event. You've got about 10 minutes to ask questions. I'm very happy to translate your questions from Chinese into English. You are welcome to type your questions from the Q&A box or from the chat box. Any questions? I have not to say any questions. I've got one question for Professor Brodney, and thank you for the presentation about the support for the family cares. And I've got the questions for the Australian government's policy to reduce disparities in the supporting of the family members who care for the people with dementia at home. Thank you.
Sorry, I didn't quite catch the question, Lou.
Yeah, have you say the policy changes? Perhaps I'll ask in a different way. The policy changes to reduce from the government to reduce the disparities in the supporting of the family members from different cultural backgrounds. Thank you.
Yeah, not really. I think, Lily, you might know the answer to this better than me. Bianca, who's our speaker at the next one of these seminars, is also more involved. But what we know is there's more translation of materials into different languages. There is more counselling services in different languages and different cultures. But there are some nursing homes which have become specific for different cultures. For example, in Sydney, I think there are 2 Chinese-specific nursing homes. There is a new Arabic-specific nursing home being built in Lakemba. And there are certainly Greek and Italian nursing homes specifically for those, because they were the big migrant populations in the 1950s. And there's Jewish nursing homes, and a lot of the nursing homes are faith-based, religious-based. So there's a Catholic and the Uniting Church. In fact, they are some of them, and Anglicare. They are the major providers of nursing homes.
Thank you, Henry. I've got one question from the chat box. The question is, how is the dementia online staff employed, paid or unpaid? And perhaps it's about it's not the online staff, perhaps it's about the staff you mentioned who have been employed in the community and the nursing homes, paid or unpaid?
Yes.
Thanks.
So the nursing homes pay for the staff, and that's their biggest cost. And they've tried to save money by having fewer registered nurses and having more nursing assistants. And one of the recommendations from the Royal Commission was there has to be a minimum number of registered nurses and trained nurses present as well. But costs are the main, wages are the main costs for nursing homes. Food is pretty cheap, really. They can feed a person for something like $8 a day, 3 meals and so on. So it's not always the great quality, but they can do that. And then providing some activities in the nursing home, so you're not just fed and clean, but you're actually engaged in activities. Most nursing homes have a diversional therapy or activity officer. Sometimes it's a nurse who's being put in that position. As far as community workers, they're usually paid for by the government, unless they're working with one of the religious organisations who provide community services. So, for example, the government will say, we are going to release 100 new aged care packages in this area of Melbourne, let's say. And they say, who would like to run these 100 packages? And so different groups, usually the churches, will put up a tender, they'll put up an offer, and the government will say, well, you have a track record, you have the experience to be able to do this. So we'll give you the funding for those 100 care packages for 3 years. And then you have to do what's required, and we will monitor it to make sure that that's fulfilled. So it's a combination of funding, and then sometimes the consumer has to pay a certain amount, depending on how wealthy they are, and what they're being asked to provide.
Thank you, Henry. The next question is from Professor Huali Wang from Peking University. I read through the question to you. I would like to learn more about how the continuous dementia care is organized in Australia. Would you please give us an example to show how the efforts of the different policy sectors are integrated? Thank you.
Wally, I know Wally well. That's a great question. In fact, that's one of the things we're trying to do, is trying to integrate these services. And they're not well integrated. I could have put that up as a challenge too. And Li Fei Lo, who you may know is a collaborator of ours and on many projects, is actually trying to do this project right now to try and better integrate care. The other piece in the puzzle, which I didn't talk about because of time, was hospital care. So we know that from a large study, 1 in 4 people with dementia will go into hospital in a year. People with dementia are much more likely than non-dementia people the same age to go into hospital. In hospital, they'll have a longer length of stay, they'll have more complications, they're more likely to die. And so hospital care needs a lot of improvement. Now, integrated care could prevent some of these hospitalizations and also prevent some of the complications when people leave hospital. A significant number of people come into hospital from their private home and end up in a nursing home. Now, with a better rehabilitation program, we might be able to prevent some of those things. And as I mentioned, as one of the issues, we have this divide between the state, which runs the hospitals, and the Commonwealth, which runs the nursing homes and other facilities. And so integration requires some cooperation between the states and the Commonwealth. And while the integration can save money if it's done well, can save time. So for example, a patient is seen by the GP, seen by the specialist, seen by the aged care assessment team, provided with a provider of services, and each one of those might do an assessment to find out what's going on. It wastes a lot of time and resources. If it was all electronic medical records, everything was available, we could integrate these things much better.
Thank you, Henry. And the next question is from our project team, Professor Mingxiao Zhu from Nursing College of Macau. And her question is about if we follow the policy in dementia care from Australia, and what sort of suggestions, if they follow the policy in Macau, what sort of suggestions you give to them?
Yeah, okay. Well, first of all, I'd like to say hello to my friends in Macau. I'm an honorary professor at your college, so that's it's always a pleasure to hear from you and visit you. You know, this is an Australian model. It's not necessarily something you can import into every country. In fact, you can't import. Every country has to decide on their own. But to me, there are many things I haven't talked about, the high-tech side of things. You know, the medications, the MRI scans, the PET scans with amyloid imaging, the new blood tests that are becoming available. You know, this is not part of what we're talking about here, which is about dementia care, but they are important. So the country has to decide where will they get the most benefit from investment. So I think the benefit is in getting a diagnosis and talking to the patient and the family what the diagnosis means, and the fact that diagnosis is the beginning, not the end. There is so much that you can do to live positively life with dementia. And if we can support the families and the person, we can work together. And it's not high tech. It's a lot of communication. It's providing time and education to those people. So that's where I'd put my priority as the first step. Then we also need to change the way community looks at dementia. We never used to talk about cancer. It was always, shh, it's hidden. But now we do. People are much more open. And people are starting to be open about their dementia. And so that's another issue. If we can reduce the stigma and people can come forward and ask for help, and then they can ask their friends and their families to help as well. So I remember I was in India and I was sitting in on a carers group, and one woman was saying her father had dementia, but she didn't want to tell anybody because it was such a source of shame. And if she told people that her father had dementia, her daughter, who was now in her about 20, would never get married because there was mental illness in the family. You know, there was this stigma that we could never talk about it. And so the father, an older man, was kept virtually locked up in the house. So other people couldn't see him because of this dementia. And, you know, I see people with dementia who live many years in a loving relationship with their family, enjoying activities, going for walks, listening to music, doing the things they like doing that don't require short-term memory, and having a good quality of life. And I see many carers who are particularly stressed and often suffer, you know, see psychiatrists or psychologists to try and get some help with that. But if we can reduce their burden by giving them the tools on how to cope, which is what our program is doing, led by Lily, then we can help there.
Thank you, Henry. Most probably you answered the next question already. The question is from Professor Yan Hu, School of Nursing, Fudan University, Shanghai. And her question is, I just read through. Thank you, Professor Broadley. Excellent speech. Could I ask what is the current strategy in Australia in reducing negative impact of the stigma to dementia patients and the caregivers?
Yeah, I think it's lacking. I don't think we have a policy at Australian-wide level. And that's one of the issues. Dementia Australia, I see advertisers on television quite a lot. There was a couple of movies that came out last year, this year. One was called Supernova, and it was about an author who had early dementia, and his partner was Colin Firth, and it was a road movie. They were driving, and the man with dementia had decided that he was going to kill himself rather than be a burden on people. And the other movie was The Father with Anthony Hopkins, which won Academy Award for Best Actor. And he was a man who was totally confused and mixing up who his family was, who wasn't his family. In fact, watching the movie, you became confused. You didn't know who was doing what. And these give such negative stereotypes about dementia. And I was really angry after that the movie about the man who was going to suicide. That there's no recognition that there's so much more that can be done to have good quality of life with dementia. So I don't think we have a good policy in Australia. I think it happens. Dementia Australia is attacking it. It really needs to be done at that sort of national level. It can't be done in a micro level.
Thank you. The next question is from our project team member, and Dr. Xiaohao Ula. His question is about research. Thank you, Henry. Great talk. I just wondering, is there any Australia database for enhancing and dementia and quantitative dementia research for the betterment of the community?
So any database on what research people are doing, a clearinghouse for researchers? Look, we tried to stay. Interesting. We tried to set that up 30 years ago, I remember in the 1980s, so late 1980s, we tried to do that unsuccessfully, I must say. No, there isn't such that I know of, such a database. But let me just talk about data for a minute, because one of the big changes in the world of research is big data. And now all funding agencies, certainly in the US and Australia, now say, once you've done your research, you have to make your data available. And so there are many large data sets now that you can make application to interrogate. We did something called the Memory and Aging Study, which was a 14-year follow-up of 1,000 people, 1,037 people from the electoral roll in a part of Sydney. We followed them up every 2 years. We did neuropsychological testing, MRIs, genetics. We did a lot of, we published a couple of hundred papers from this study. But that database is sitting there. And Parminder Sachdev, my close colleague, has established a consortium of studies around the world looking at longitudinal aging. It's called COSMIC, C-O-S-M-I-C, COSMIC. And it has something like 41 or 43 studies from around the world. And everyone shares their data on a repository, which we hold. And anyone can apply to access those data. And in the United States, there are many such big data sets. And now with genetic research, now there are massive data sets because people need like 100 or 200,000 people to have enough power to show the small effects of certain genes. So data is important. And I did mention that earlier. And I've become a real convert to big data. And we need more data, and we need it at a population level.
Thank you. The next question is from, again, team member, Associate Professor Jing Wang from Xi'an Jiaotong University. Her question is about, thank you, Professor Brondley, for your wonderful presentation. You mentioned that caregiver support is very important in dementia support. What's the priority you think in caregiver support? Thank you.
All right. Well, first of all, let me say hello to my friends at Jiaotong University in Shanghai. I was a visiting professor there once, and I was visiting there, I think, 2 years ago in April. So my priorities, I think, are education and training and emotional support. So, but what I think the navigator system is what I've been pushing our government with unsuccessfully. So the idea is when something goes wrong in dementia, you call somebody, you get some help, and then it's over. It's episodic. You get an episode of care. With a navigator system, a diagnosis, you would be assigned to somebody who would be your navigator. They might spend some hours with you in the first few weeks after diagnosis, and then they would just be there for you to call if needed. And they could then help you down that journey. And it would not be episodic, it would be continuous. And it wouldn't be reactive, it would be proactive. Now, instead of having a major crisis because my husband become aggressive, I could ring up my navigator and say, I'm not sure if I'm handling things right, because every time we talk about something, you end up having a fight. The navigator said, well, it sounds like your communication strategies might be improved. Why don't we have a talk about it? Or why don't you go and see so-and-so who can talk to you about it? And you can prevent that escalation to aggression and then put them in the nursing home because they're too aggressive. So we need that sort of service, ideally. But we have to show that it's cost effective because it's a huge amount of money to fund these positions. But if we show we can save people going to hospital, keep them at home longer, because nursing homes are expensive, and prevent exacerbations, which use up a lot of resources, then that may convince governments.
Thank you, Henry, again. And thank you for our audience because of the time and we cannot go further. However, I have had a look at your questions already. We'll reply to you by email or in another means. And we will have more webinars throughout the project and more presentations from our team members, including our team members from the Great China. The next one is scheduled on 11th October 2021. We will send information to you and invite you to the next presentation. Thank you. Thank you, everyone.